Hi, everyone. I want to welcome everyone to the third webinar or meeting in the Supporting People with Autism and Catatonia Through Education and Support series. Today, we have a very special guest. We have Dr. Isaac Baldwin from Vanderbilt University to talk about the diagnosis of catatonia. Dr. Baldwin got a degree from Colorado Christian University and a medical degree from University of Kansas Medical Center. Right now, he was a resident and now is a fellow in the Department of Psychiatry at Vanderbilt University Medical Center. And he works with Dr. Joshua Smith, who you will hear from in the future. Sorry, if
Uh,
everyone could
okay.
mute themselves. I will I will try and mute people. Um, so thank you, Dr. Baldwin, for joining us. Before we continue, I just want to go through a few things. Number one, please keep yourself on mute. Number two, ask questions through the Q&A panel right here, but introduce yourselves and have an ongoing chat here. I want to separate out Q&A so I make sure that I'm keeping up with the Q&A. But please introduce yourselves, talk amongst yourselves within the chat function. And then finally, I am going to, we're recording this. I'll be posting it on the YouTube page. I will post a link to the recording in the chat a few times, as well as a link to register for the next in the series, which is the next three. So those will be pharmacological treatment of ECT, I'm sorry, of catatonia ECT, and then also a session with the Catatonia Foundation to talk about supports. So without further ado, I am going to turn it over to Dr. Baldwin.
Thank you, Alicia, and thank you for inviting me. I'm really excited to be here with you all and talk about a really important aspect of catatonia and autism. My talk is titled, How is Catatonia Diagnosed? That's the important question that we wanted to talk about today. This is a perspective specifically for catatonia in autism, but it really should capture a lot of catatonia diagnosis in general, and also neurodevelopmental disorders more broadly. Again, I'm Isaac Baldwin. I'm a child psychiatry fellow here at Vanderbilt. Really grateful to be here with you all. Don't have any financial conflicts of interest to disclose. Some disclaimers. Opinions are all my own. I'm unable to provide any diagnostic impressions or specific recommendations for individuals today. We're currently building the body of evidence for catatonia and autism, which means that there's a lot of things we still don't know. And I'll try to be clear about what we do know, how we know it in terms of what kinds of studies have been done, and some of the things that we aren't sure about or that are based more upon clinical experience than they are upon big data sets. Also, I'm going to be talking a lot about children and adolescents with catatonia, but there might be some differences between that and adults. This is just because this is more of what my experience, both clinically and research, has included. But I have a lot of experience treating adults with catatonia as well. And so try to touch on some of those things throughout and make it clear when things are different between kids and adults. So our aims for today, I want to share an introduction on how catatonia is diagnosed. I don't think I'm going to be able to really clearly demonstrate what catatonia diagnosis looks like for every individual in this one talk, but I want to talk about it a little bit and give a general overview. We'll talk about the features that clinicians look for when we are looking for catatonia, talk about assessment for catatonia and autism spectrum disorder specifically, and why it's both complicated and a really important thing to think about. While we're talking about that, we'll talk about the concept of deterioration from baseline, which is a really important concept in autism and catatonia specifically, and the Lorazepam challenge test, which is the gold standard diagnostic test. The diagnostic process doesn't end once catatonia has been diagnosed, though. There's still a lot of work that needs to be done, so we'll talk about that. And we'll talk about the importance of continued assessment, that oftentimes it takes several meetings with a physician over a long period of time to really get to the bottom of what might be causing the catatonia and how to treat it most effectively. So why is accurate diagnosis of catatonia important? It's because mainly it's a significant quality of life issue. It causes aggression, self-injurious behavior, impulsivity, decreased oral intake that can be very harmful to individuals, and it's treatable. So we never want to miss this condition because it can cause some really significant issues, but we've seen that people can get a lot better when they get the right treatment. It can also be lethal in severe cases. Now, this is not the majority of cases. This is a relatively small minority that develop malignant catatonia, but it is a really severe condition that often needs an ICU level of care, often needs ECT to improve significantly, and needs to be treated quickly because of the potential for lethality. It's also important to differentiate behavior related to catatonia from other medical causes and psychological changes. If we're not thinking about catatonia, we may miss a condition that is treatable, and we may not differentiate it from other potential medical causes that need to be thought about as well. So who most often identifies catatonia? It's hard to say overall, over the whole country or from a global perspective, but I can give you a perspective from just our children's hospitals where we've been doing some of this research recently. So in our setting, psychiatrists were the overwhelming majority, and especially consultation liaison psychiatrists, which just basically means psychiatrist consultants that are working in the children's hospital. And you can see here, everything blue is a psychiatrist. And so psychiatrists are really the people that have the most training in catatonia and diagnose it the most commonly, at least in our setting. Though we've seen, as we've been growing some of our education efforts here at Vanderbilt, we're seeing more pediatricians, neurologists, and other folks recognizing catatonia. But oftentimes the Lorazepam challenge test is really what clinches the diagnosis. And that's often something that we will handle ourselves in the hospital. So we'll talk a little bit about the criteria here, starting with the DSM-5. What I want to point out here is that it only requires 3 or more of these symptoms, which is actually a fairly low bar in terms of the diagnosis of catatonia when you look at other methods of diagnosing it that go beyond the DSM. I'll go through these here because I think that this is a good opportunity to talk about some of the most important features. The first one, catalepsy, basically just means if I reposition the patient's body, so say I lift their arm up in the air, then they will continue to hold that posture against gravity and just hold the arm up in the air continuously. Waxy flexibility is slight and even resistance. So a continuous resistance when I'm trying to move the patient's arm, where the resistance is the same in both directions and maintains the same amount of resistance. Stupor, which is just not moving, essentially, not actively engaging with the environment, kind of just being very still and uninteractive. Agitation, which can look like aggression, but it can also look like just restlessness. And the DSM calls out here not being influenced by external stimuli, which I think is important, but sometimes really hard to kind of figure out in an individual clinical case. Mutism, which is little or no verbal response. But this can look really different depending on the person's verbal abilities at baseline. And so that's something we'll talk about a little bit more. Negativism is opposing or not responding to instructions. It can also look like doing the exact opposite of an instruction that's given. Posturing is adopting a posture spontaneously. So I'm not causing the patient to start a certain posture, but then they do it themselves and then continue it for a while. Mannerisms, which is like an odd caricature of a normal action. So for example, someone might pretend to brush their hair repeatedly as if they're holding a hairbrush. Stereotypies are repetitive, abnormal movements, non-goal directed, can commonly occur in autism. And I'm sure you've already noticed as we're looking through some of these that some of these features also pop up in autism generally. So we'll talk about that a little bit more. Grimacing is odd facial expressions, especially involving the mouth. Echolalia, mimicking another speech, another thing that's common in autism. And echopraxia, or mimicking another person's movements. So moving on to the Bush-Francis catatonia rating scale. If you've heard anything about catatonia, you've probably heard of this scale before. It's kind of the gold standard scale that's the most well-validated for assessing for catatonia symptoms. It has 2 major aspects to it. The first one is the screening items. So these are, you don't need to have all of these, just at least a couple of them to move on to more specific examination for catatonia. I'll call out a couple of things here that are different than appear in the DSM. One of them is verbigeration, which is making an abnormal non-speech sound, oftentimes repeatedly. Also withdrawal, meaning decreased intake of food and drink by mouth. This is one of the most common reasons that we see folks presenting for catatonia diagnosis, because it's a really significant quality of life issue and oftentimes can start really quickly and suddenly. The severity scale is only completed if 2 of the screening items are present. And these are each rated on a scale of 0 to 3 for most of them, but some of the severity scale items are just present or absent. So we're not assessing for how significant it is. I'll call out a few things here. Impulsivity means like essentially what you might assume, not thinking before acting, but oftentimes when we see it in catatonia, it can look like randomly grabbing at things or running out of a room or running into traffic randomly. Automatic obedience, which is immediately engaging in whatever behavior is requested of you without really seeming to think about it or consider whether or not to do the behavior. Mitgehen and Gegenhalten are 2 German terms. Those come from the history of catatonia, which I think was talked about in one of the earlier talks by Dr. Wachtel about when this condition was first described in kind of the German-speaking world. Mitgehen means to go along with, so oftentimes we will press up on a patient's hand and ask them not to let us push their hand up, but they will just go along with it and not provide any resistance. Gegenhalten is equal and opposite resistance. So when I was talking earlier about moving a patient's limb and feeling the resistance there, Gegenhalten, the resistance is proportional to the force applied. So if I try to push the arm really hard, I'll get a lot of resistance. If I try to push it more lightly, I'll get less resistance. Ambitendency is being stuck between doing and not doing something. So oftentimes we'll see a patient walk up to a doorway, attempt to go through, then take a step back, then attempt to go through again, and kind of get stuck trying to go through a doorway, for example. Oftentimes when we're testing for this one, we'll ask the patient to shake our hand and then to not shake our hand. And sometimes when we ask them to not shake our hand, but we extend our hand toward them as if we're trying to give a handshake, they'll get kind of stuck and be confused about whether or not they're actually going to complete the handshake. Grasp reflex is just what it sounds like. It's kind of stroking the patient's palm and seeing if they grab onto your finger. Perseveration is abnormally repeating oneself either through words or through actions. Combativeness can look a lot of different ways, but it means kind of what it sounds like, aggressive form of agitation. And then autonomic abnormality. This one's really important because it's the main way that we differentiate malignant catatonia from catatonia in general. So if you see increased blood pressure, increased heart rate, increased temperature, those things can all score as an autonomic abnormality. And when those things get really severe and really refractory, like they're not responding to our normal treatments, then that's when we consider it malignant catatonia. And we get really worried about needing to get the person to ECT quickly. There's not a lot of great videos out there of individuals with autism or other neurodevelopmental disabilities who have catatonia and the specific symptoms they can show. But there are some resources that are videos about how to look at these symptoms and how to assess them. So this is a great series of videos. You can just Google this kind of headline at the top here, Bush-Francis Catatonia Rating Scale Assessment Resources, and find this website. It's from the University of Rochester, where Dr. Oldham and Dr. Wurtzel, who are great docs who work in the catatonia kind of realm and do research in that area. They also are great actors, apparently, and have created a series of videos where you can watch how a Bush-Francis examination is done and what some of the symptoms might look like, even though it's all acted out. The next thing I want to talk about is the pediatric catatonia rating scale. This is one that is more validated in children. The Bush-Francis is really well validated in adults and the most well validated scale overall. But this one tries to approach kids specifically and think about how they might present with catatonia differently. So here it adds a few things to the Bush-Francis. It includes most of those, but I've listed out some of the things that aren't on the Bush-Francis, including incontinence, schizophagia, which is a scrambled speech, acrocyanosis, which could look like bluing of the fingertips, and automatic compulsive movements, which I think of as just kind of a general way of capturing a lot of the abnormal movements that can happen in catatonia that don't clearly fall into one of the categories that are on the Bush-Francis. The next thing I'm going to talk about is the Connor catatonia rating scale. This is the last of the scales. I'm not going to be talking about scales the whole time. This one is designed to be really specific for neurodevelopmental disorders. It's not as well validated as some of the other scales, like the Bush-Francis, but it does add some really important extra symptoms to look for, like flaccidity, which is the opposite of rigidity. So that abnormal resistance you can get in catatonia when you're trying to move someone's limb, you can get the exact opposite. And it seems like that might be more common in neurodevelopmental disorders, where you lose that muscle tone when you're catatonic. Nudism is just abnormally removing clothing. Incontinence, again, the metronome test is an interesting one where you kind of start the person's arm swinging, and then usually most of us will allow that to kind of come to rest after a second, but a catatonic person might continue their arm swinging indefinitely. And then magnetism, which is kind of abnormally reaching for the examiner, oftentimes the examiner's hand, when you're trying to do an examination. So what can these features look like? I'm really fortunate to be able to share a video with you today that a family member of one of our patients here at Vanderbilt has allowed us to share. This patient came in with really significant behavioral changes. And I just want to put out a little warning out there that this video can be a little distressing, just because there's a lot of yelling and some kind of impulsive, agitated behavior in the video. But important to know, this kid ended up getting a lot better with treatment for catatonia. So I'll go ahead and play that video, and then we can talk a little bit about what we're seeing.
Luke, you wanna watch a movie? You wanna watch Paw Patrol? You wanna watch Paw Patrol?
So I'm going to pause the video right there to just point out a couple of things. So the first thing that we saw in the video was what I would call excitement, which is just a lot of agitated behavior, a lot of energy. A lot of times patients that are exhibiting excitement, which is a catatonic sign, will not be able to stop themselves from moving to rest for a long period of time, just continuous kind of frenzied movement. The next thing we see is posturing. The child throws a chair and then immediately adopts this kind of abnormal posture. Now, if this was the child's posture a lot of the time, if he was consistently showing this kind of a posture, then we might not do that. We might not count it as posturing. But in this case, he adopts the posture, he holds it for a very long period of time, and it's out of the ordinary for him. And then the last thing is this repeated yelling. This is one of those things that's pretty subjective, and so different clinicians might have different interpretations of what to call this yelling behavior that he has. I'm calling it verbigeration here because this is an abnormal non-speech sound, and it's also repeated in a very kind of stereotypical way, where it's the same exact sound repeatedly. There are probably other things that you could notice in this video that are suggestive of catatonia, but these are the clearest ones to me, so I just wanted to point those out. So what about baseline versus catatonic features? These are some really important things to think about in autism and catatonia because the baseline features of autism can look like catatonic features and vice versa. So some autistic people show some of these features at baseline, but seeing these features does not always mean that catatonia is present. So that's really important to recognize. And a thorough diagnostic process is required, including things like a physical exam, like this doctor is doing. So talking a little bit about some of the research that we've done here at Vanderbilt and in collaboration with some partners around the country, including most especially Mass General, we have found that children and adolescents with neurodevelopmental disorders have higher Bush-Francis scores than those without. and that some features are more common than others when we're diagnosing catatonia in pediatric patients, especially staring, mutism, immobility, decreased food and drink by mouth, posturing, and rigidity. So these ones are really important to look for when you're thinking about pediatric catatonia. And pediatric patients also had higher average Bush-Francis scores in our study, around 15, compared to adults patients in kind of larger studies of catatonia, which are around 4. We think that one thing that is probably contributing to this is that a lot of the patients that we see in the children's hospital have neurodevelopmental differences. And so they likely have higher average symptoms on the Bush-Francis catatonia rating scale even prior to developing catatonia. So oftentimes when we're trying to differentiate baseline versus catatonic features in a kid who is neurodevelopmentally different and has some of these features at baseline, it can feel like walking on a tightrope, and it can feel a little bit uncertain. So here's some of the things that we think about. In general, with catatonia, the most common features that we see are new onset speech impairment, negativism, and aggression. And this is especially true of individuals with neurodevelopmental disabilities. The problem is that some of these can be difficult to differentiate from other causes. Aggression, for instance, is not always due to catatonia. Some of the ones that we think, based on our clinical experience, that might be more specific would include new speech impairments and decreased food and drink by mouth. Though you can have catatonia and not have either of these features. So that's why it's so important to go through the whole process from beginning to end of doing the Bush-Francis evaluation and really looking into each of these features individually. So this brings me to a discussion of the personalized score and catatonic deterioration. There's a great paper by Drs. Houtman and Dr. Wachtel, who gave one of the earlier presentations, where they make this point that catatonia leads to behavioral and skill regression, but not all regressions are catatonia. So then how do we look for catatonia in an individual that has neurodevelopmental differences? And one of the most important things when we're starting this process is to realize that we can't assume that the baseline score on the catatonia scales is always going to be 0 in autism. So we'll talk a little bit more about what that means and why it's important. So what's this personalized score at baseline? It is, first of all, an estimate. We're not going to be able to know exactly what we might have scored an individual before they developed catatonia on these scales. It's based upon family report mostly, or caregivers or friends. You also can incorporate documented resources like medical notes, IEPs, school testing, that sort of thing. And also home videos, which is something I want to focus on because it can be really, really helpful when we're making a diagnosis of catatonia. So how do we do this assessment? When I am working with a family and they are concerned that their family member has catatonia, or they're concerned about a big behavioral change and they're not sure what's caused it, I will start by gathering some kind of general history about the patient. And then when I've started to get a suspicion for catatonia, I'll describe the symptoms from the Bush-Francis scale, from the pediatric catatonia rating scale, from the Connor catatonia rating scale. And I'll basically ask, was the person showing this sign before the big change or not? And other general questions like, what could they do before the change that they can't do now? What kind of skills have they lost potentially? And oftentimes what I'll find is that it's really difficult for people to think back, and it's really hard for me to ask the right questions to get at how was the person doing 6 months ago? It's much easier to think, how were they doing around Christmas or around their birthday, for instance? So I'll often use that to kind of anchor our memories and help us remember specific times of the patient's life and how they were doing. And events like that, oftentimes also there are videos taken. And so using that kind of a timeline tool, that kind of using the home videos to build a timeline can be really helpful. So the catatonic deterioration from baseline concept is essentially just the difference between the baseline estimate. So we kind of come up with, what do we think your Bush-Francis score was before you developed this big change in behavior, and the current score. Based upon what I'm seeing today, I create a score and I kind of figure out how different it might be. And I always ask about these 6 red flag symptoms. So these are really important things to think about if you're a family member who might be concerned about catatonia, to present these kinds of things to physicians, because they help to create kind of a helpful story of what has gotten worse and are any of those things really concerning for catatonia. So the red flag symptoms are worsening of movement concerns, new refusal to eat, worsening incontinence, loss of specific skills, new or worsening aggression without a clear cause, or new or worsening self-injurious behavior without a clear cause. Having these 6, even if you have all 6, does not necessarily mean that you have catatonia, but it means that we definitely need to do a good assessment and consider catatonia as a potential diagnosis. Some important things to remember when you're talking as a clinician with a family, or if you're a family member talking to a clinician, is what do we mean by baseline? Well, baseline is basically the person's normal behavior, but taking into account the natural ups and downs that we all can have. We all have good days, we all have bad days. So we want to think about that baseline as an average day, not as the best day that's happened ever, but rather like, what does a normal day look like? And also remembering this is really important, and something that is not really well described in the literature yet, but something that we've seen in our clinical work quite a bit, is that people can lose all kinds of communication abilities. You'll recall that I said that mutism is an important feature of catatonia, but actually you can lose all kinds of different communication abilities, and we've seen it in catatonia in patients that we've taken care of. Decreased use of sign language, decreased use of assistive devices, gestures, writing. We've seen all of these things present with catatonia before. So even if the individual is non-speaking at baseline, that doesn't necessarily mean that they can't lose those communication skills when becoming catatonic. So some helpful information that families can provide for clinicians: home videos. Want to say this one again. Videos of the person walking, talking, playing, eating, doing other daily things that they used to do, like brushing their teeth or using a tablet. All of those things can be super helpful because they're providing us some information about how the person was functioning when they were functioning well in the past. And it's the type of things that you often need to do during the day. And so we can observe them and see specific differences that we might not think to ask about before we've seen the home video. Also, a written developmental history. This is something that some families have already had when they've presented to care with us, and that's been super helpful. Knowing when the person started walking, speaking, how many words they were using before they developed the catatonia, for example. And other times we've had patients where it wasn't clear that there was a neurodevelopmental kind of underlying issue, but after they developed catatonia, we look back and we talk about the developmental history and we find a bunch of information that's really helpful for us in determining what's their kind of trajectory over time looked like. Documents are really helpful: IEPs, educational testing, notes from occupational therapy, physical therapy, speech therapy. They're just kind of looking at the things that we are interested in when doing those therapies and doing those kind of educational assessments. And so it can be really helpful to have a specific point in time where someone has documented how the individual is doing at that point in time. Ruling out other causes of symptoms is really, really important. We certainly always never want to miss catatonia, but we also never want to miss any other things that might be causing the symptoms. So during assessment, clinicians should think about other potential causes. This is part of our job to go through the list and check off different things that could be causing the symptoms. General medical issues like constipation or infection can cause similar symptoms. Neurologic issues like seizures, and environmental causes like an individual trying to communicate a need in a way that is different than they used to be doing in the past. Now, if you have all of the catatonia symptoms, there isn't one of these things that can explain all of those symptoms by itself. But we want to make sure that we're not misinterpreting some specific feature or some specific symptom as catatonic in nature when there might be another cause that needs to be addressed separately as well. So this brings us to the Lorazepam challenge test. This is a really important aspect of the diagnostic process, something that we do with every single patient that we are considering catatonia for in our clinical work. It's the gold standard diagnostic test. And just last year, our group, led by Dr. Lucarelli at MGH, published a paper where we had 54 patients that were children and adolescents, and we showed that the Lorazepam challenge test is effective in this population, which is something that we didn't really know before. Definitely still need a lot more data collection about this. Because there's some things that we still don't really know for certain about how the Lorazepam challenge works and how to do it best. So what the classic way of looking at the Lorazepam challenge test is that we're looking for significant reduction in symptoms. Oftentimes that's considered a 50% reduction in symptoms. But what we're finding is that that 50% reduction target, it may not always be useful in autism because of what I talked about before, that autistic people can have some of these features at baseline. So we have to be really careful and consider that when we're thinking about this. For example, you could have a patient who has a baseline Bush-Francis catatonia rating scale score of 0, and they could have a Bush-Francis score of 17 when they become catatonic. If their symptoms come down after giving 1 to 2 milligrams of Lorazepam, they can come down by 50%, and that can make us really certain that catatonia is the correct diagnosis. But let's say we have an individual whose baseline Bush-Francis score is a 9, and they're coming in with a Bush-Francis score of 17. If we are hoping for a 50% reduction in that score with Lorazepam administration, that's a really high target to shoot for. We're looking for better than baseline at that point. And so that's pretty unrealistic. And I think what we've seen is that a significant reduction that's going toward baseline can oftentimes be enough for us to say that catatonia is present. And also we're looking at the features changing that are the new ones. So if the individual has baseline features that are positive on the Bush-Francis scale, we're looking for the new features that are not their baseline features to improve when we administer that medication, though sometimes we can even see baseline features improve. And then we also want the patient to not become overly sedated. The medication Lorazepam can cause people to get sleepy, and that's kind of the normal response that we would expect to the medication if an individual is not catatonic. So if we see them get sleepy, that can make us feel more so in the direction that they may not have catatonia. But we also can sometimes provide a dose that's a little bit too high. And in those cases, we'll see that after the patient feels a little bit more alert after getting the Lorazepam, that their Bush-Francis score has fallen. So that's something important to think about as well. So thinking a little bit more about the Lorazepam challenge test, it's important to address this big question in the field right now. Should we do the test differently in autism? It's really difficult to know. And like I said a minute ago, we don't have a lot of great data about how to do this test best, though we know that it works effectively. In our study, we found that there was no significant difference between individuals with and without neurodevelopmental diagnoses in terms of the necessary dose of Lorazepam, the route, whether we gave it by mouth or through an IV, and the time between when the dose was given and the time that we came back to reassess the patient. None of those things seem to really differ. So that can make us feel good that we are likely doing it well, because there's no real reason to feel like we need to be doing it differently in autism at this time. But there definitely needs to be a lot more research done to feel really confident that that we're doing it as well as we could be. So what happens after a positive Lorazepam challenge test? Well, essentially, the diagnosis of catatonia has been made, but we often need to do more clinical tests or more laboratory tests that can look into possible causes of catatonia. And these causes can be causes in autism and in individuals without autism. So depression, trauma, psychosis, those things can all cause catatonia in individuals who are autistic and individuals who are not. Drugs, including prescription medications, neurologic conditions like genetic conditions, infections, tumors, and autoimmune conditions. A lot of times, if neurologic conditions are the cause of catatonia, we'll see other features that are concerning for an underlying neurologic diagnosis, but we always want to think about those potential causes in every case of catatonia. So after we finish the Lorazepam challenge and we're doing this diagnostic testing, it can feel really uncertain about what tests need to be done or what the next steps are in terms of diagnosis. And so at Vanderbilt, we've tried to create a clinical roadmap for working up catatonia. The first thing that we do is we look for signs of autoimmune encephalitis, which is a condition in which the immune system attacks the brain and really frequently results in catatonic symptoms. It also usually comes along with other abnormalities like seizures, like other psychiatric concerns that are new and acute, and it usually comes on pretty quickly. In every case, we will do some laboratory studies, and we'll at least consider doing brain imaging in every case of catatonia. If there are signs of autoimmune encephalitis, we often consider doing an EEG or electroencephalogram or more specific labs to make sure that we're not missing autoimmune encephalitis. Oftentimes, this workup process includes a lot of coordination with our hospital pediatrics colleagues, can also include collaboration with rheumatology and neurology, especially when we have concern about autoimmune encephalitis. So next, after we have symptoms stabilized, which you'll hear more about in later presentations in this series, I'm not going to talk about the treatment, but we'll just mention that generally what we do is we start patients out on a regularly scheduled dose of a benzodiazepine like Lorazepam after we've seen a good response to it. But oftentimes once we get the acute symptoms stabilized, we transition to outpatient care. But that doesn't mean that the diagnostic process is over. Oftentimes, we aren't totally positive what has resulted in the new catatonia onset, especially in autism. And we want to make sure that we're continuing to think about those things as we transition to outpatient care. So we need to evaluate how patients are responding to the treatment and adjust it to get the right regimen while doing some further kind of diagnostic consideration and making sure we've really looked through all the history effectively. There's this tool that I wanted to mention here because it kind of fits into the concept of diagnosis because of the idea of ongoing assessment. Now, we can feel pretty confident that catatonia is the correct diagnosis if the Lorazepam challenge test is positive and goes really well, and the patient is responding well to the treatment that we start, usually a scheduled benzodiazepine like Lorazepam. But we want to do ongoing assessment to make sure that we're seeing symptoms continue to improve. And there's this concept of a daily catatonia report, which I think can be really helpful to kind of work up things over time and see how symptoms are responding to treatment. There are 18 really plain language questions that families, caregivers can use to track symptoms at home. And then they have a really objective kind of data points to use day by day that they can present to their physician and talk about with them. This has not yet been validated, meaning that we don't know how well this tracks with how bad the symptoms actually are. If we were to do the Bush-Francis, for instance, we might see significant differences between this report and the Bush-Francis. But it is a really helpful way of just reminding yourself as a caregiver, what are the things that I'm looking for to see if things are improving or not? Another important thing to recognize when we're thinking about ongoing assessment is that in autism, some of the symptoms will remain chronically for the majority of patients. So we see symptoms improve a lot, but oftentimes they will continue over the longer term. And a lot of times we need to maintain the patient on at least some dose of a medication like Lorazepam, sometimes adding other medications, and sometimes going to ECT. So the overall diagnostic process, I just want to kind of go back through it step by step. It starts off with vital signs and a physical exam. This is really important because we want to make sure that the person is getting the right level of care for them. Sometimes we can have patients that haven't ate or drank anything for several days, and that can mean that they need to go to the hospital. But other times they might be eating or drinking, doing okay with nutrition, but their vital signs are really out of control, and that means that they need to go to the hospital. So we always want to start with that step. The catatonia rating scales we'll do. Oftentimes we'll do multiple catatonia rating scales, but pretty much always the Bush-Francis at least, based upon what we're seeing right there in the moment. Then we'll create this kind of estimated score at baseline. Sometimes that can look like sitting down with a family member and going through each item of a scale. And sometimes that can mean kind of getting a general picture overall of, is this a big difference or a small difference in terms of these specific symptoms on the Bush-Francis scale. We'll often do that in cases where we feel that treatment is really urgent and we just need to get a rough kind of a guess at around where their score would be at baseline. The Lorazepam challenge test is the next step, giving 1 to 2 milligrams of Lorazepam either by mouth, IV, sometimes intramuscularly when necessary. And then treatment and ongoing assessment, knowing that we're probably not going to see full resolution of symptoms in the first couple of days of treatment. So it's going to take further appointments and further medication changes to get to a really good place. While we're doing that diagnostic process, we are also doing other diagnostic processes simultaneously. So investigation of potential alternative causes of symptoms, what might be other things that could be causing the symptoms we're seeing, and also medical workup for potential causes of catatonia. We never want to assume that we know the reason before we've done at least some basic laboratory studies and really done a good physical exam to make sure we're not seeing anything abnormal that needs other diagnostic tests. So some take-home points for this talk today. Catatonia symptoms will present as a change from baseline behavior. While we see that a lot of patients have sudden changes, some patients have slower changes. Some patients have symptoms that can last weeks or months or even years before they arrive at treatment to us. But oftentimes we'll have seen them develop some skills, develop some abilities, and then lose some of those things or start engaging in behavior that they hadn't been doing before. Some symptoms of catatonia can look like baseline features of autism. This is a really important thing to recognize because sometimes clinicians can get really confused about what might be a symptom of catatonia because they've seen it before in autism. So trying to differentiate that and making sure that the clinician understands what the patient's behavior was like in the past is really important. Next, that the Lorazepam challenge test needs to be considered with the individual's baseline features in mind, thinking about not expecting that number to go down by 50% if their number wasn't 0 to begin with is really important. Needing to look into potential alternative causes of the symptoms we're seeing and underlying causes of catatonia. Remembering that home videos can be really helpful in diagnosis. And then that assessment and diagnosis is an ongoing process that can take some time and usually isn't over when we have completed the Lorazepam challenge test. Here are my references, and I'll move past that pretty quickly to get to my important slide, which is this thank you to Alicia for having me, to Josh, Dr. Smith, my mentor, who has been really instrumental in helping me to develop my research and clinical skills when it comes to catatonia, Dr. Wachtel, whose research features very prominently in my presentation here. I encourage you all to go watch her presentation. That was the one just prior to this one, if you haven't already. And then the Department of Psychiatry at Vanderbilt and the Children's Hospital, Monroe Carroll Jr. at Vanderbilt. So thank you all for having me. I really appreciate it. I'm looking forward to being able to answer some questions, but I'd also invite any other clinicians that are on the call. I know we have some that if you guys have thoughts about any of the questions or anything that we discussed, I'd love to have more of a discussion about that because there's a lot that we're still trying to figure out about catatonia, and I'd love to hear everyone's thoughts.
Thank you. And thank you for a great presentation, for being so clear and the perfect tone for this. We did get some questions. One of them was a few of them around lorazepam. So I'm going to go over those first. One, what if someone is allergic to lorazepam? Is there an alternative?
Yeah, that's a really good question. Lorazepam allergies are something that we don't run into that commonly, but what we do see commonly is people that have had abnormal reactions to lorazepam in the past. And what we found is that those folks that when they've gotten lorazepam in the past maybe had gotten more dysregulated, they tend to actually respond well to lorazepam if they are experiencing catatonia. So it's just kind of like a different syndrome that they're experiencing in that moment that responds differently to the medication. As far as allergies go, there are other medications that have been tried for challenge tests in the past. We personally have used diazepam here at Vanderbilt, especially when there was a big shortage in lorazepam. And then there's also some non-benzodiazepine options that have been tried, like the Z drugs, which are sleep medications, like sopiclone, for instance. Things like that have been tried in the past.
What are some of the starting doses for this? And do you do it IV or oral? So what would be the starting dose for, let's say, lorazepam and then the root?
Yeah. So oftentimes we'll either do 1 or 2 milligrams of lorazepam for the first dose. And we'll do that kind of generally weight-based, but it's kind of a guessing game. Generally, like an adult-sized person, I do 2 milligrams, and a child-sized person, I do 1 milligram. And depending on how they respond to that, we may end up giving another dose immediately if we see a little bit of improvement, but not much. And whatever dose we end up arriving at that gets a good reduction in symptoms, we'll end up using that same dose 3 times a day, every 8 hours for the next 24 hours and assess how things have gone. We usually also allow the teams to use additional as needed doses if the symptoms get worse or if there's a lot of agitation, and we'll incorporate that into that 24-hour dose and then use that same dose going forward over each 24-hour period.
And then what if there, as much as you try, there is no response to a lorazepam challenge? Do you rule out catatonia at that point?
Really good question. So sometimes yes, if we can find a good cause that seems like a realistic alternative cause, we will rule it out. If we can't find a good alternative cause, or if the symptoms are so clearly catatonic in nature that we just feel so strongly that this is catatonia, even though it's not responding, we will move very quickly to doing ECT. We've seen cases like that in the past, especially ones that come on really quickly and are associated with malignant features like vital sign abnormalities. They don't respond very quickly to Ativan, and then we have to go to ECT really fast.
Dr. Siki, I'm sorry, am I pronouncing that correctly?
It's psych, like psychiatry.
Dr. Psych, do you want to add something to that?
I had a separate question that wasn't exactly piggybacking off of this. So I'm a psychiatrist in Ohio, and I do treat some patients in this population. One of the things that I have sort of noticed is that trauma is usually a big part of the story. Sometimes more of a chicken and sometimes more of an egg. I think going through the difficult process with the healthcare system of getting to the right diagnosis, the treatment itself can be kind of dramatic if you're hospitalized and have ECT, especially if you might be in a state that where you're not able to process as much information, or you are and people don't realize that and aren't giving it to you. That I've found that trauma really tends to follow in the wake of this for patients and also their loved ones. If there's a primary caregiver, say a parent or a spouse or a sibling, how is that something that you assess for? And if you have any thoughts about how we might like try to address that in this population, because that's been a barrier.
Yeah. Yeah, absolutely. Thank you for bringing that up. That is a really important point. And I would agree. In my experience, we see trauma as a precipitating factor for catatonia in autism really frequently. And we also see kids experiencing a lot of trauma because of the treatment, because of some things that happen during their catatonic episodes. And then the family goes through a lot of trauma too. We definitely always assess for trauma. We're always asking questions about precipitating events, and we ask about specific types of trauma. Even things that families might not consider traumatic can be very traumatic for an individual on the autism spectrum. And so sometimes we'll see things that are just stressful experiences that we might not usually consider traumatic being precipitants for catatonia. So we always assess for that. In terms of how to help, I think all hands on deck is the best way that I can describe it. We really need a trauma-informed way of working with these patients, and I think that's something that we're trying to develop in our clinical care, moving from the children's hospital and our consult team through to outpatient care, providing as much behavioral support as we can for families. Something that I think has been really helpful for us is that here at Vanderbilt, we have family support specialists who can actually check in with the family between admissions and between outpatient appointments to just talk about caregiver burnout, to talk about resources in the community, and things like that. So I think that's really helpful. And I also think there could be a really big role for psychotherapy in catatonia as an adjunctive treatment for those whose symptoms have already improved quite significantly. And we need to do some more research to figure out how best to implement that as well.
We had another question about the question is the deterioration from baseline. Do you require that for a diagnosis? And then also, what is the time span? Does it need to be sudden, or is there kind of more a gradual time span?
Yeah, this is a really great question because it's a really active area of debate and discussion in the field. So the classic way that we understand catatonia is that it is a deterioration from baseline, and that's what makes us feel really confident that catatonia is where the symptoms are coming from. If we see a catatonic deterioration from baseline that responds to lorazepam, we can feel really confident about it. There's a lot of discussion in the field, though, and there's a really great paper that just came out this past week or two from the World Journal of Psychiatry about should we understand self-injury and autism as something along the catatonic spectrum more generally than we are right now? Because we do see patients that have chronic symptoms that can respond to some of our treatments for catatonia. And so that's still an area that needs a lot of research and work. But I do think that at the very least, we can say that catatonia can come on slowly, that it can come on over the course of weeks or even months of time.
Thank you. Another question that came in almost at the beginning was, is giggling or laughing for hours considered agitation? Is it mania? How does that fit in with the catatonia symptoms?
Yeah, this is a really good example of one of those things that I was talking about, where there are specific symptoms that can be related to multiple different causes. So aggression's a good example. You can have a kid become aggressive when they're constipated, for instance, or when they're trying to communicate a need, but it can also be related to catatonia. I think that giggling, it really depends on how it presents, how acutely it came on, if there are any things that are triggering it. We can see giggling start due to lots of different things, but I would say that it could fit into catatonia if it was surrounded by lots of other symptoms that were suggestive of catatonia.
And then someone had a question. There were two questions actually that came in. One is the utility of Prozac. And then the second is, how do you manage or how do you kind of assess if somebody is already on antipsychotics? And in fact, some of the symptoms may be, or the diagnostic evaluation may be kind of confounded by an action of a neuropsychotic. So I'm kind of grouping those together in terms of drugs drug
Yeah,
interactions.
sure. Yeah, that's a great question. So Prozac, interesting one because it can be really, really helpful for kids that have depression, anxiety disorders, baseline irritability. And
No.
we see that sometimes when the catatonia is actually related to an underlying cause that is an anxiety disorder, significant improvement when that anxiety disorder is adequately treated with something like an SSRI. And I always think of catatonia as kind of like a fever. It's a syndrome where we see all of these individual symptoms, but there's an underlying cause that we'd like to try to address many times. And so depression, anxiety can be those things. So Prozac can be helpful. Prozac can also cause some restlessness.
Great, thank
That can
you.
also look like catatonia. So that's important to think about. In terms of antipsychotics, this is a really tricky one because antipsychotics in general carry some risk of worsening or causing catatonia. That's been documented in the past. But there are also cases where antipsychotics can be helpful in treating catatonia, especially medications like aripiprazole or Abilify or olanzapine, which is also Zyprexa. We've seen good improvement with those. Clozapine is a medication that has actually been used to treat catatonia itself, even when the underlying cause is not known. But if there is an underlying psychotic disorder, many times the antipsychotic is needed and we will co-treat. So many times if the patient's already taking an antipsychotic, they haven't had any changes to that medication, but they've become catatonic recently, we won't necessarily always stop the antipsychotic. Many times we'll try to initiate the benzodiazepine first and see how they do with both.
I have another question that's different than pharmacology, but hopefully you can help. So someone wrote in that their daughter is an AAC user. What sorts of words would you expect someone who's using an AAC device to, to communicate with, to let the physician or the parent or whoever know what's going on internally? Like do you know of any sort of, I guess this is a good question for someone that's experiencing catatonia. What words would they use? I don't know if that's something you can answer.
Yeah, that's a really good question. There is some good papers and testimonials from people that have experienced catatonia in the past, and they kind of fall into one of two categories. Many patients have really impaired memories from during their episode of catatonia, so they aren't able to give a good description of what was happening. But the ones that can, what we've seen is that many times they experience really significant fear. There's a great book about the history of catatonia called The Madness of Fear, that talks about how catatonia has been understood throughout history and how really that fear response is the primary underlying thing when you talk to people that have experienced catatonia that kind of results in those symptoms that we see.
Well, we're at the 2 minute or 2 o'clock mark, at least 2 o'clock on the East Coast. I am going to put in the chat a link to the next 3 sessions right now. That is to register for the next 3 sessions. The first one will be about pharmacological treatment, including Lorazepam and also some immune modulating drugs. And then the one after that will be about ECT. And then the final one will be about resources. So I've gotten a couple questions about resources. If we didn't get to your question, I'm sorry about that. Hopefully, if you rewatch this session or watch a future session, many of your questions might be answered, maybe not. But I want to thank Dr. Baldwin again, and also Dr. Smith, his mentor, for such an amazing presentation, so clearly and succinctly spelling out what it is like to get an evaluation. So thank you very much, and I look forward to seeing everyone on the next meeting.
Thank you.
Thank you.